Hello, my name is Emily Wegg. I'm an assistant professor and attending physician at the University of Washington and the Seattle Cancer Care Alliance, and I'm happy to walk you through the ways in which we work together with our prostate cancer patients to prepare them for proton therapy. So I will share my screen. Today, I'm going to cover a little brief introduction into radiation therapy. We're going to walk you through the timeline for treatment, what exactly fiducial markers and a rectal spacer mean and the role that they serve, what exactly a radiation simulation is, and we'll also address treatment duration. So to start with a brief introduction to radiation therapy, on the right, you can see a picture of a treatment room here at our Proton Center. And on the left is a schematic of what's going on the cellular level. So radiation uses ionizing radiation that enters a cell and causes DNA damage. Cancer cells, as opposed to healthy cells, are particularly vulnerable to this type of damage, and it causes cancer cell death. Our healthy cells, of course, are not immune to damage from radiation, and so the art of radiation therapy becomes maximizing the therapeutic ratio, which means straddling the fine line between maximizing the benefit or the efficacy of treatment, meaning optimizing cure rates, while minimizing the risk or the potential side effects of treatment, meaning optimizing quality of life post-treatment. And this is where all of the nuances of radiation therapy planning and technique come into play. Prostate cancer has been an exciting frontier for radiation therapy. Our technology has evolved rapidly and continues to do so. This diagram is purely meant to introduce what I like to call the alphabet soup of radiation therapy. So these words like IMRT, and IGRT and SBRT are where patients who are making the extra effort to self-educate may start finding themselves lost in the weeds a little bit. So in broad strokes, what these represent are evolving techniques that have refined our ability to deliver higher, more ablative doses to the tumor, while enabling us to minimize the dose going to healthy tissue. As we know, protons are a form of external beam radiation therapy, and this graph is called a depth dose curve and represents the dose that your normal healthy tissues and tumor tissues are exposed to. This top curve represents photon therapy or normal conventional X-ray therapy, and everything under the curve represents the tissues seeing radiation. The y-axis represents the dose to tissue at this depth on the x-axis. And so the beige shaded regions demonstrate the areas of normal tissue that see radiation with photons that are spared with protons. Protons are the red lines. The peaked curve represents the famous Bragg peak, which represents the pinpoint deposition of therapeutic dose into the tumor that's associated with protons. In fact, it's so pinpointed that we have to add things to the beam to spread it out so that that therapeutic dose can adequately cover the tumor. And this is called a dose color wash. It shows the way that concept that we saw in the last slide kind of plays out in the bodies of our patients. So on the right is a photon or an X-ray plan, and you can see what's called a dose color wash. The red represents the highest dose of radiation. The purple is intermediate. The sky blue and the green are colder. And photon plans, especially with older techniques, would deliver what we called a low dose bath to the entire pelvis. Our newer techniques, including protons, which is shown on the left, create beautiful plans that deliver hotter doses than we used to be able to give. And that means more likely to kill cancer cells, and also with much less radiation going to all of your other pelvic tissues. With protons, prostate target coverage is equivalent to photons, but protons can reduce this low dose bath, which is also called the integral dose, to the non-target tissue. And this comes with a theoretical benefit that protons may decrease the risk of secondary cancers as well as long-term normal tissue damage and side effects. So next, we'll go through the timeline for treatment. You know, a lot of you have probably started moving through this timeline, but first patients are seen in a consultation with a radiation oncologist. That's when we review all of the details of your cancer history, your other medical history, your social history, your family history, and we make a recommendation about whether or not you may be a good candidate for radiation and specifically what form of radiation we might want to use. And then if the physician and the patient together decide that they want to proceed with proton therapy for prostate cancer, the next step would be to schedule an appointment to have, it's a brief procedure to have fiducial markers and potentially also a rectal spacer injected. And we will walk through what exactly that means in just a moment. After that brief procedure, about a week or two later, typically the patient would come back for the simulation, which I'll also walk through shortly. That's the radiation planning session. The physician then runs through works on planning that patient's radiation plan. So for every patient, we develop a radiation plan that is specific to your disease and your anatomy. About 2 weeks after the simulation, the patient comes back to start treatment. And then once you finish treatment, you are in the follow-up phase. So let's talk for a minute about what fiducial markers are. Fiducial markers are 3 markers that get placed into the prostate, and this is done in a brief procedure where we use a transrectal ultrasound, which is similar to the ultrasound used at the time of prostate biopsy. Using the ultrasound, we guide needles into the prostate that inject these 3 tiny markers. They are about the size of a dry grain of rice, so they are very small and they can't be felt. They don't cause any discomfort once they're in the prostate. They are injected in 3 different axes, and we use them to help guide the patient's setup every day when you come for your treatment. So when a patient comes for treatment every single day, we take a picture of the patient in the treatment position, and we look for these 3 markers. And we make sure that within millimeter, they're exactly where we want them to be. And that is our final check that everything is set up perfectly before we start the treatment. Here you can see an example of the kind of images we get here at our Proton Center. It sort of looks like an X-ray, and we get one from the front of the patient. This is if you're looking straight at the patient, and you can see these little bright white vertical lines. Those are the 3 markers, and we want them to fall inside these circles, and this patient is setting up beautifully. And here's a picture that we take from the side. So here you can see the tailbone. This is the femoral head and the femur. And here you can see that also in this, from this perspective, at this angle, all 3 markers are lining up perfectly. So that's how we use these markers. And then often at the time when those markers are being placed, we consider placing a rectal spacer, which is also called a space OAR or a spacer. And what this is a hydrogel that gets inserted through using that transrectal ultrasound. There is a needle that gets placed in the perineum. That's the area of skin between the scrotum and the anus. That needle gets guided into the space between the prostate and the rectum. The hydrogel gets injected into that space between the prostate and the rectum and essentially pushes the rectum a centimeter away from the prostate. Now, a centimeter for a radiation oncologist is like a mile. If we can push that rectum about a centimeter away from the prostate, we can really minimize the amount of high-dose radiation that we see. So it's a nice approach for patients who are candidates. We know that patients who get this gel have lower rates of inflammation in the rectum long-term. So it's a nice intervention. And it actually gets absorbed by the body 4 to 6 months after it's placed. So we place it, it's there while we need it, and then it goes away. But not everybody is a candidate for this. And here's a picture of it. This is somebody, we are looking into the patient as if we cut them right down the middle. So here is a bladder to get you oriented. This gray blob outlined in blue is actually a prostate. This outlined in green is a rectum, and this bright thing that's outlined in pink is a spacer. And you can see that it pushes the rectum away from the prostate. So if the radiation comes down and circles the prostate, we're really staying farther away from the rectum. But when we don't like to use a rectal spacer is when there is any concern that there may be some cancer cells in this space between the prostate and the rectum, because the last thing we want to do is disrupt cancer cells or potentially move them further away from the prostate and out of the radiation field. So, not everybody can get a spacer. When we can, we use it and it's great. And most patients who don't get a spacer also do just fine. And in terms of rectal sparing approaches, many people may have heard of a rectal balloon, which is something that our center used several years ago, but doesn't use anymore, although is still in use at several facilities. And so just to try and clarify some of the differences between a hydrogel spacer and a rectal balloon, the purpose of a hydrogel spacer is really to increase the distance between the prostate and the rectum, as we saw on the last slide in that picture. The purpose of the rectal balloon is not to increase the distance between those two structures, it's more to increase the reproducibility of that rectoprostatic anatomy. The rectal balloon is something, if you're not familiar, that gets inserted during stimulation and every day during the radiation treatment, and is essentially a balloon that is inflated to the same volume every day for treatment and helps to make sure that the rectum looks exactly the same and that the rectum and the prostate are in a very reproducible position every day for treatment. So that's the role of the rectal balloon. The spacer is placed once. The rectal balloon is placed at simulation and every daily treatment. The advantages of the rectal spacer, the hydrogel spacer, is in sparing the rectum from seeing high doses of radiation. The advantages of the balloon is maximizing the reproducibility of that daily setup. The disadvantages of the hydrogel spacer, there is a handful of patients have a little discomfort. The procedure can be uncomfortable when we place it, and then some patients feel a little bit of residual fullness. And like with anytime we put needles into the body with anything, there's always a potential risk for infection, although that risk is very, very small. The potential disadvantages with the rectal balloon are that we increase tension on the rectal wall, and we may actually be pushing the rectal wall closer to the prostate. So these are both reasonable approaches. Our center now uses a hydrogel spacer and does no longer use a rectal balloon. So let's talk a little bit about radiation. That's the radiation treatment planning visit, when the patient would come in and we would lie the patient down in the treatment position, which for prostate cancer is when the patient is lying flat on the back with the legs straight out ahead and the arms are resting comfortably on the chest. We make an immobilization device that is like a plasticky material that goes under the patient's legs and hardens to the shape of the body. And that immobilization device, or that mold, is used every single time that patient comes back for treatment to help us get that patient set up in the exact right position every day. So that's the immobilization device. And then we get a CT scan, and then we give the patient 3 tiny little tattoos. They're like little dots or freckles, but they are permanent. And those are also used to help triangulate and make sure that the patient is lying in the exact right position every day for treatment. The other thing that we do for the simulation and for treatment every day is that we ask the patient to have a full bladder and an empty rectum. So what exactly does that mean, and why do we do that? Well, we'll start with the full bladder. The bladder is like a balloon. It can be empty and collapsed down in the pelvis, or it can be full, at which time it moves up into the abdomen. And you can see here these pictures. I'm not sure if you can see my mouse. If you can, I'm encircling the bladder on this picture. This is if we cut into the patient, you can see the bottom of the spine and the tailbone, and the white thing at the front is the pubic bone. And right in between them is the bladder. And on the left, it's kind of collapsed and empty. And on the right, it's full. So what a full bladder does, and we make a full bladder by drinking water simply. And usually the recipe that I find works the best is to drink about 2 cups of water 45 minutes before this treatment. And that's enough to fill the bladder. And when we fill the bladder, we actually push the bowel out of the pelvis and up into the abdomen. So we push the bowel out of the way of the radiation. And the other thing the bladder does is that instead of the bladder being collapsed in the radiation field, we're pushing all this bladder tissue out of the way of the radiation as well. So a full bladder is a very simple intervention that does a lot of good. And the other thing we do is we aim for an empty rectum. because the position of the prostate can change a bit from day to day, depending on how full the bladder and the rectum are. So we pay a lot of attention to these, and we try and make it as reproducible as possible. So we do that with a full bladder. And for a rectum, we aim for the empty rectum simply by asking the patient to have a regular daily bowel movement, ideally before their treatment every day. We recognize that nobody is a machine, so if that can happen every day, that is okay, but we do our best. And what we really want to avoid is constipation. So we talked about the full bladder, the empty rectum, we make the immobilization device, we get a CT scan, we give the little tattoos. Sometimes we also get an MRI after the simulation. And then we take that information and we start working on your radiation plan. So for every patient, we create a radiation plan that is specific to your anatomy and your disease. And here's an example of what that planning process looks like behind the scenes. So we take your scan and we draw out our target, and we draw out some of the structures, your healthy tissues in the area. We calculate the doses to everything and make sure that they are meeting all of our criteria. And this is a planning process that involves the physician as well as dosimetrists and physicists. Here are the dosimetric guidelines that the physician provides to the dosimetrist and physicist. They then can feed these guidelines into the treatment planning software and work on developing a radiation plan that they then come back to the physician with. And then there is an iterative process where we go back and forth until everybody is very happy that we've created a really nice plan that can be delivered safely and effectively to the patient. What you can see here is all of these structures nearby to the tumor have very clear instructions for how much radiation they can receive and to what volume of that structure. We look at the bladder, the rectum, the bowel, all sorts of structures. So about that planning process typically takes roughly 2 weeks, and then the patient comes back and gets started on treatment. And lots of patients these days are asking questions about how long the treatment planning is. And there are all sorts of regimens out there that are reasonable and appropriate. And so we can talk a little bit about what it means to have different durations of radiation therapy prescribed for you by your provider. And a lot of this comes back to the concept of hypofractionation. Hypofractionation means fewer hypofractions. One treatment session of radiation is called a fraction. So there has been a movement over the last several decades to decrease the duration, the length of radiation treatment from being something that we used to treat in 8 or 9 weeks to now being something that we treat in a more convenient, shorter period of time. And the reason why we do this comes back to something called the alpha beta. Now this is going to get a little bit hairy, but bear with me for a minute. It's a characteristic. The alpha beta is a characteristic that's assigned to all of our tissues, our healthy tissues and our tumor tissues, and it reflects the tissue's ability to repair itself after damage from radiation, and how that ability to repair is affected by the dose of each treatment delivered. So it gets fairly technical, but prostate cancer has one of the lowest alpha beta ratios, which means it's very sensitive to larger doses per treatment sessions, meaning prostate cancer cells cannot repair themselves well after they're hit with a large dose per treatment session. Whereas the healthy tissue that surrounds the prostate are better able to recover from those higher doses than the prostate cancer cells. So we can take advantage of this by delivering higher doses in each treatment session. And that means we're able to condense treatments that used to take 8 or 9 weeks to 4 to 5 weeks. And we can do that because we have also developed the technology to do that safely, including all the things that we've seen so far that we've reviewed that go into radiation planning, interventions that make sure that your daily setup is spot on, interventions that make the radiation more pinpointed and carefully shaped so that we can send these higher doses into the prostate and feel confident that it will be well tolerated. So that's the sort of biological rationale for hypofractionation. And then there's the socioeconomic rationale, which is that 8 or 9 week treatment can be logistically and financially toxic for patients. And so if we can deliver something, and I love this quote at the bottom, it's rare that nature hands us a cancer situation where an improved treatment goes hand in hand with a shorter and more convenient one. So if we can do this treatment and make it more convenient and just as, if not more effective for patients, then that's certainly something that we want to be doing. So, and then there is a natural evolution, as multiple randomized controlled trials have demonstrated that moderately hypofractionated radiation is comparable to conventionally fractionated radiation. So going from 9 weeks to 5 weeks with regard to cancer control and toxicity, how much more can we push this concept? How short can we make these treatment, this treatment duration? And that is an area of ongoing investigation. And so you may see patients at our center treated with 44 treatments. There are still some patients who we think may benefit from that longer treatment course. There are some patients having prostate radiation 28 treatments or 20 treatments. They're all equivalent when it comes to cancer control outcomes. There are many considerations that go into choosing one approach over another. That includes anatomical considerations, what the patient's baseline urinary function might be, other illnesses that may increase their risk of toxicity, such as patients with inflammatory bowel disease, whether the patients had prior pelvic surgeries or procedures in the area, as well as physician comfort and preference. So that completes my presentation for today. Hopefully that helps elucidate some of the planning and processing that we work together with our patients to help get them ready for proton radiation for their prostate cancer.